Very good evening to everyone. Today I'll be speaking on ilioinguinal and iliohypogastric nerve block. The indications for ilioinguinal iliohypogastric nerve blocks include intra and postoperative analgesia following suprapubic and inguinal surgeries. For example, inguinal hernia repair, orchidopexy, hydrocele repair, varicocele repair. Also, in combination with T12 and T11 and 12 intercostal nerve blocks, it has been used for postoperative analgesia after renal transplant surgeries. It has also been used for surgeries via phalangeal incision like laparotomy and LSCS, and also for chronic pain management for patients following with persistent post herniorrhaphy pain. However, the experience has not been very good in this regard. The main contraindication here is only local infection. So we'll discuss a little bit of relevant anatomy here. As we are all aware, abdominal wall innervation includes T6 to T12 thoraco-abdominal nerves, intercostal nerves, and also a contribution from L1, which course through the lateral abdominal wall in a plane between the transverse abdominal muscle and the internal oblique muscle. This plane is the TAP plane, transverse abdominis plane. So this plane, this intermuscular plane, these nerves course in this plane and they are amenable to block at this level. Ilioinguinal and iliohypogastric nerves, they originate mainly from ventral rami of L1 with contributing filaments from T12. And however, there are a lot of variations and even L2, L3 contributions have, and also somewhat T11 contribution have also been described. Ilioinguinal and iliohypogastric nerve, they provide sensory innervation to the inguinal region mainly, and also to the skin of the suprapubic region and the hypogastric region, and the inner thigh and the scrotum and labia majoris. They are effective in reducing the opioid requirement in the pediatric population following inguinal hernia repair, and the effect has been comparable to caudal block. So this is one a main block which has been utilized for this surgery. So, coming to the origin of these nerves, they form a part of lumbar plexus. Both of them they originate at they emerge at the lateral border of the psoas major and then run infrolaterally on the ventral surface of the quadratus lumborum muscle and then transverse abdominis muscle and the this transversalis fascia, and just they run just superior and parallel to the iliac crest. And ilioinguinal nerve lies below the iliohypogastric nerve at this level. So at the level of anterior one third of the iliac crest, they tend to pierce this transverse abdominis muscle and land into the transverse abdominis plane. But it is highly variable. Iliohypogastric nerve enters the TAP plane a little bit earlier as compared to the ilioinguinal nerve. And ilioinguinal nerve generally enters very close to the anterior superior iliac spine. So they pierce internal oblique muscle at a variable level, which has been described to be 3 plus minus 2 centimeter medial to the anterior superior iliac spine and 1 centimeter superior to the inguinal ligament. Anatomical variability therefore contributes to a high failure rate of ilioinguinal iliohypogastric nerve with the landmark technique. Posterior to the anterior superior iliac spine, both of these nerves will lie in the TAP plane. And infromedial to the ASIS, they ascend to pierce the internal oblique muscle, and they lie in the plane between the internal oblique and the external oblique. It is a point to be noted here is that they only provide somatic analgesia and do not provide a visceral coverage. Also, a little bit of contribution from the genitofemoral nerve contributes to a relative failure with this technique, which may lead to a sparing of the dermatomes. They then ascend through these muscles. They pierce these muscles and internal oblique, external oblique, and then supply the inguinal region and the related area. A study of 25 neonatal cadavers measured the distance from anterior superior iliac spine to ilioinguinal and iliohypogastric nerve. They were found to be in the region of around 2 millimeter on the left side, and on the right side, ilioinguinal were measured around 2 millimeter from ASIS in neonates. And for the iliohypogastric, they were around 3.3 to 4 millimeter from ASIS. Ultrasound study of 50 patients with 50 pediatric patients reported a mean distance of ilioinguinal nerve of 6.7 millimeter and a mean distance from ilioinguinal to peritoneum of around 3.3 millimeter. So the point here is that the distance from the anterior superior iliac spine, it varies a lot with the age and growth of the child. So a landmark technique with a fixed distance is likely to fail. And also, if you can note here that the peritoneal distance is very short, only 3 millimeters. So a little bit of slip with a landmark technique, the needle is likely to land into the peritoneum and can injure the peritoneal structure. Also, one more thing here is that the facial plane between the transverse abdominis muscle and the transversalis fascia is in continuity with the space around the femoral nerve. So this can contribute to the femoral nerve blockade with the ilioinguinal blockade. First, coming to the landmark guided technique, the needle insertion point is around 2.5 millimeter and medial to the anterior superior iliac spine on a line drawn between the anterior superior iliac spine and the umbilicus in this line. So, however, this is for pediatric patients and it can vary from 1 to 5 millimeters. For adults, it has been described to be a point 2 millimeter medial and 2 millimeter capillard on the line joining the umbilicus and the anterior superior iliac spine. Here, a short bevel needle is advanced perpendicular to the skin like this, perpendicular. And while appreciating the loss of resistance, the clicks, facial clicks, which will mean a loss of resistance. So a pop sensation will be felt as the needle will penetrate the first layer, that is the external oblique aponeurosis at this level. And at this level, with the landmark technique, first 5 ml of local anesthetic is injected so as to cover the iliohypogastric nerve, which may have left the fascia, left the transverse abdominis plane a little bit earlier. And then we proceed to further second click, and then at this level of second pop, we this needle will lie in this tap plane, that is between the internal oblique muscle and the transverse abdominis plane. And here another 5 to 10 ml of drug is injected so that there will be a split in the fascia between the internal oblique and the nerves will be covered with the local anesthetic. Now, while coming out in a fan-shaped manner on the subcutaneous plane, another 5 ml 3 to 5 ml can be injected to cover any sensory supply from the intercostals or other subcostal nerves which may be supplying this area. So first we appreciate the two pops, give 5 ml in each pop, each LOR, and then we inject in a fan-shaped manner at the subcutaneous level. However, this block has a very high failure rate of around 30%, and the complications such as femoral nerve block or peritoneal puncture are more likely because the needle may not lie in the precise plane. And the distance from peritoneum in children with around 40 months of age was found to be around 3.3 millimeter. That is around 3.5 years. The distance will be around 3 millimeter from the peritoneum. So the risk of peritoneal puncture is very high with landmark technique, especially in children. Now coming to the ultrasound technique, which is now a bread and butter for inguinal hernia surgery in children. The main equipment which is required is ultrasound machine with a linear transducer because it is a superficial block, then sterile sleeve and gel, then standard nerve block tray with syringes of 20 ml of local anesthetic. The volume required would be 0.3 ml per kg of 0.25% levobupivacaine, which has been described for landmark technique. However, in expert hand, for ultrasound guided technique, only 0.075 ml per kg of 0.25% bupivacaine each side is sufficient. 5 to 10 centimeter nerve block needle is used depending on the habitus, body habitus, and 21 to 22 gauge needles are used and sterile gloves are used. Now coming to the sonoanatomy, the when the probe is positioned so that the one end of the linear probe lies on the anterior superior iliac spine and the other end is oriented towards the umbilicus, then we will identify these muscle layers. That is, all three muscle layers may be identified, or sometimes external oblique muscle may not be visible at this level because it has turned aponeurotic. So external oblique fascia may be visible. Then we may see only two peritoneal, only two muscle layers, that is internal oblique and transverse abdominis. So we can see either three layers or two layers here. And then here you can see this is the external oblique, this is the internal oblique, and this is the transverse abdominis. As always, internal oblique is the thickest nerve, and in between the internal oblique and the transverse abdominis, that is the tap plane, at this level of ASIS, when the probe is oriented towards the umbilicus, we should be able to see these two nerves, which will appear like peas in the pod. That is the ilioinguinal nerve, iliohypogastric nerve, and sometimes the deep circumflex iliac artery will also be there together. So they will be within 1 millimeter of each other. So this appearance will be known, will look like a peas in the pod appearance. So with this dorsal circumflex, deep circumflex iliac artery, it can be visualized by using a Doppler. If there is a doubt, we can use a Doppler. It will be in the same plane as this nerve. So when this is identified, it will serve as a landmark to identify this fascia and the nerves. So it is a useful landmark, additional landmark. Many times we may have a doubt about a relevant plane is this in this region because the preperitoneal fat sometimes appears as a transverse abdominis muscle. We have to be very cautious. So then what we can do is then we can caffalad, we can spread, we can then slide the probe upwards or caffalad or caudard, and maintaining the same probe orientation over the iliac crest, we slide the probe slightly caffalad and slightly caudard, and then we can identify these three muscles in view. We will generally get these three muscles in view, and then we can identify the relevant plane very easily. So then immediately below the transverse abdominis muscle will be the fascia transversalis, and immediately below that the peritoneal structures with peristalsis movement will be easily identified. So the trick here is that we should always identify the deepest structure first. The deepest muscle will be the transverse abdominis, and then we can count upwards and then we can find the relevant plane. So we should identify the peritoneum first and then we should count upwards. So this is what I was talking about, the peas in the pod appearance of the nerves, which are two hypoechoic structures which should be visible here. So I'm sorry about it. This is a supine, the block procedure is done in supine position. In children, it may be under general anesthesia. And then palpation of ASIS is palpated so that you get an initial orientation for the probe placement. Then one end of the probe is placed over the anterior superior iliac spine, and other end is oriented towards the umbilicus. And then this oblique plane should show, as soon as you place here, you should see these two nerves in view in the tap plane. Then if we are not able to see, we should try to locate the deep circumflex iliac artery and use the color Doppler to identify it. And then in the plane, we should use in-plane technique for needle insertion from medial to lateral or lateral to medial, but generally medial to lateral orientation is preferred. Then also out of plane approach can be used in obese patient where in plane approach may be insufficient for the needle length. And also this for out of plane approach, we may find it difficult to locate the needle tip. So what we can do is keep injecting 0.5 to 1 ml of the saline till we see a split in the fascia between the internal oblique and the transverse abdominis, we should be able to see a clear kayak sign, clear splitting of the fascia. That is, unzipping of the fascia should be visualized. Then the target is a local anesthetic spread in this plane, tap plane, in the vicinity of these two nerves. Drug 0.25% levobupivacaine, ropivacaine, or bupivacaine can be used. Then 10 ml per side is 10 to 15 ml per side is generally sufficient for adults, while 0.15 ml per kg will be required for children. This is the block procedure. This is a neonate who presented with the obstructed inguinal hernia. The probe has been placed with one side over the iliac crest and one side facing towards the umbilicus. So this side should be a shadow of the anterior superior iliac spine. Little bit of the shadow is visible here. And this is the P in the pod appearance of the nerves. We can slide the probe above and downwards to visualize these nerves together. And then we can insert the needle in plane from medial to lateral and aim towards this fascia between the internal oblique. This is the internal oblique. This is the external oblique. Aim towards this fascia, and when the needle reaches this fascia, just inject a 0.5 to 1 ml of the drug or local anesthetic. And in children, remember that the local anesthetic volume is very, very limited, which you can use. So we should not waste the local anesthetic for hydrodissection. We should always use a little bit of saline to check for the correct needle placement. And then when the needle is correctly placed, then only we should place the local anesthetic. Also remember, the system should be completely closed. It should not have any amount of air because in these planes are very, very delicate, and any amount of any small bubble of air will impair the vision. And for the subsequent needle insertion, it will be very, very tough to visualize this plane. This is how we are placing the needle in the adjacent to the nerves. Also remember that we should not aim for the for the nerve directly. Here, first the needle is aiming directly to the nerve. So we slightly withdraw a millimeter and then go past the nerve so as to spare the nerve, and we should not be injuring the nerve. Also, the deep circumflex iliac artery should be visualized carefully, and we should not be injecting there so that there is no there is no local anesthetic toxicity. In children, it is very much possible even with a small volume. And you can see a clear separation in this plane with the transverse abdominis muscle settling down. So tips for this nerve, remember always to identify the muscle layers from inside out. When we are counting from outside towards inwards, then there can be a confusion regarding the subcutaneous fat, which may be counted as an additional layer. So always look for the peritoneum, the moving structures, then count the first muscle layer, that is the transverse abdominis muscle, then internal oblique, and then external oblique. And then the fascia between the internal oblique and the transverse abdominis will be easily visualized. And then there we will be looking for these two nerves. We should be performing a dynamic scan before we do the actual needling. We should be deciding the target. We should adjust the probe angle, the gain, the depth to obtain the best possible image. In the video which I showed, the depth of the structure was less than 1 centimeter. So we have to be very, very careful in children. In small children, it will be very superficial. So if we are not careful to visualize the entire length of the needle, we may end up into the peritoneum very easily in these patients. And also if our needle tip enters a little bit interior because little bit deep, because this patients this transverse abdominal muscle layer, it is hardly any less than 1 to 2 millimeters. So if we enter deep and we inject at the level of fascia transversalis, we may end up with the motor block of the lower limb. So we have to be very careful. If there is any doubt about the relevant planes, the probe should be slided capillard or caudad over the iliac crest till we identify the 3 distinct muscle layers. So when we identify the 3 distinct muscle layer, then we should start looking for the nerves, and then we should slide it down again to the relevant area to locate the nerves and the relevant plane. That will confirm the relevant plane. If still we are in doubt somehow, so it will be better to inject in the tap plane, because that will also give a good coverage of the inguinal hernia or other indications for the ilioinguinal iliohypogastric block. The main difference being that the local anesthetic volume required may be little bit more. Then the needle, block needle should be inserted from medial to lateral orientation, and good image of the tip should be ensured at all times. As I have already mentioned, that if the needle tip is not visible, especially in small children, we will be easily lying in the peritoneum and we may injure a peritoneal structure. Also, another point here is that medial to the at the medial end of these muscles, there is a, at the level of the anterior superior iliac spine, there is a iliacus muscle is lying just over the ilium. So if we inject in the plane, if the needle goes too deep, and if we inject between the iliacus and the transverse abdominis muscle below the fascia iliaca, then it will become a fascia iliaca fascia iliaca block, and then we will land into a femoral nerve block. However, that block, if it occurs, there is no need to worry. It will dissipate very fast. The effect may be inadequate. The out of fluid technique should be considered for obese patients. There are some minimal complications, that is like block failure in up to 30% patients, colonic puncture, small bowel puncture, that may be very common in landmark technique. However, these hematoma, bowel hematoma, bowel puncture, these things are very, very remotely seen with the with this ultrasound guidance, and where we are seeing the exact plane, and if we are ensuring the needle tip visibility. Transient femoral nerve palsy may occur, which may lead to quadriceps paresis with 6% in landmark technique. So we should be cautious with, and as far as possible, we should use ultrasound guidance. It is a very, very easy block. It is a beginner level block, and it can be easily done with ultrasound. These are my references. Thank you very much for your patient listening.